Harpreet, thank you so much for joining me today. Would you mind just introducing yourself to our audience?
Yeah, thank you, Abigail. It's a great pleasure to be here. I'm Dr. Harpreet Sood, GP in London, where I've been a partner for the last few years and been a GP over the last 10 years. And I combine that role as well as being working in health technology and was formerly the Deputy Chief Clinical Information Officer at NHS England. So bringing clinical technology enabled care and then the world of policy and system redesign to my work. I also do work internationally and have been spending more time in the UAE, where I'm building a new primary care venture out here as well.
Cool. So I would say that you're right at the heart of primary care
Yeah,
and kind of driving change there. Um, if you had to pick the biggest structural flaw that there is in primary care right now in the UK, what do you think that would be?
great question. I'll say one biggest thing, but I may just tease that a little bit more and give you a second one. But the biggest one that I think structurally is a flaw which prevents, I think, a lot of the things that get outlined, whether it's in the political sphere, the policy sphere, also from a new operating model, is incentives and how we finance primary care today. And I think that as a structural flaw makes it limited in terms of what really we can do and what the art of the possible is. And so what I mean by that is that today, the way primary care is funded, i.e. general practice is funded, sorry, in the NHS in the UK, is very much through capitation. So every time you register with a practice, the practice gets a certain amount of money, and then you can get uplift depending on how unwell they are or where you are practicing. So things like quality outcome framework payments or incentive payments to look after long-term conditions, but also in more deprived areas, you may well get an uplift. The challenge with all of that is that it's generally a quite small pot of money, but it also doesn't allow individuals to necessarily invest for the patient in front of you. And what I mean by that is that not only is the quantum quite small, I believe, but I think secondly, it's not designed to think about prevention, population health in a much more greater detail, but also doesn't allow you to invest in the health of the individual in a meaningful way, is my view. And so because of that, and because of how the incentives are aligned, it means that yes, we talk about doing prevention, but in reality, there is very limited amount of prevention happening, nor is there a huge amount of money that we can then spend on things like technology, doing new models of care, thinking about long-term condition management in a different way, because the structural flaw here, which is the financing in the incentives, allow us to do very limited in what we have.
Interesting. And you did say that there was perhaps a second biggest structural flaw. Um, what would that be?
The second biggest structural flaw, I think, is that the way we've designed primary care today. Sorry, let me repeat that. Cut that. Start again. The second one is the second flaw is again how we think about delivering primary care. So at the moment, it's a very generally tends to be a very doctor-led centric model. So the GP being at the center, which is important, but the GP also often being the first port of call. Now we've started to see some elements of changes of that with, initiatives like the additional roles reimbursement scheme, where now we do have a comprehensive multidisciplinary team that works in the primary care GP setting. So you have your physios, pharmacists, health and wellbeing coaches, you have healthcare assistants, physician associates, and the list goes on. And but many practices still operate with a doctors first or doctor centric model. And I think if we're thinking about how to redesign care, a lot of these healthcare professionals can play an important role before you actually end up seeing a GP. And I think the public are still not fully aware of that necessarily, or find it hard to see that, in some ways what they feel like they're being fobbed off because they're not getting to see their GP. But actually, I believe that not all conditions or not all the things that are primary care related need to be dealt with a doctor, and they can be dealt with other healthcare professionals. And I think that ends up being a structural flaw, which ends up being because of how the model is designed today, but also then how we communicate that with the public, and also how the operating model is designed.
That's interesting because, for example, you can get a lot of advice from your pharmacist. I
Yeah,
didn't realize this until
right,
genuinely a few months ago, because people don't know.
right,
But yeah, you can. Can they, in some pharmacies, they can prescribe
exactly.
antibiotics? Is that the
Yes,
case?
absolutely.
See, that's interesting.
Certain clinical conditions can be now directly managed through pharmacy and pharmacists. And I think there's been a ongoing public facing campaigns on that. But it's hard to always get that message across because people are still used to calling up their GP, trying to book an appointment, and trying to see a GP, which doesn't always have to be the case.
Yeah. Um, so theoretically, we'll go back to incentives in just a second.
Yes.
But theoretically, how do we then shift the care system so people are relying less on a GP and seeking alternative modes of primary care as the first port of call? How exact is it? Just about raising awareness?
Yeah, raising awareness is one thing, but also how you then organize and develop an operating model that is focused on, the first port of call being, let's say, could be a nurse, could be a healthcare assistant. We can triage in different ways. And then you could have second line of defense in some ways, which is pharmacists, physios, which, can solve many of the musculoskeletal problems that we see in the primary care setting. And then you then say, okay, if these things are not being managed, or you have someone who is a complex patient that needs to see a doctor, then obviously they can go and see them. But a lot of them can be managed through other healthcare professionals. And ultimately, I would say again, I'm estimating here, or guesstimating, as they say. Probably about 70 to 80% of all clinical conditions, or what gets managed in the primary care, is being dealt by a doctor, GP. Whereas I think if we flip that, we could probably get more like 20% being dealt by a doctor or GP, and 80% being dealt by, including actually psychologists, because mental health is a big part of GP and primary care today. But we often find that doctors and GPs are still dealing with mental health issues, which is fine because obviously we can do that. But often people need counseling, therapy, and things like health and well-being coaches rather than being prescribed a pill. So it's again, how do we formulate a different new operating model? How do we really truly focus on prevention? And so again, if I give you an example, and I've talked about this previously, you know, usually I would see, in a full day of clinic, it could be anything from about 30 to 40 patients, including home visits, telephone calls, which you can see on the course of the day ends up being quite a lot of interactions, and quite a lot of, you know, times where I have to restart and do the consultation with every single member that comes in, and that interaction 30 to 40 times. Whereas, if I'm really focused on a prevention first model, my ideal day could be anything from about 5 to 10, maybe 15 max encounters, but you're spending a lot longer with the individual and or their family member, where you get to know them and providing much more of a holistic assessment, and really focusing on things that matter, rather than the 10 to 15 minutes that we end up doing as GPs, because that's how the model is designed, and that's how we are operating in terms of providing GP and primary care today. So it's again thinking about how we flip and reverse the model if we're really thinking about prevention first, which again, like I said, is what policymakers, politicians, and also a lot of the clinical community want, but the system is not allowing us to provide it that way, because of the design in the financing, the incentives, but also how the operating model works.
I mean, it's a really, it could be really, really significant because if we think about it, what the moment GPs, like you say, they get 10 to 15 minutes per patient. A lot of them end up overrunning because how on
Yeah,
earth do you squeeze? Patients also, I've
well, you
heard
can't.
that you
Yeah,
can't, and patients will kind of give a tidbit of really important information just at the end sometimes, and you're like, oh no, okay, right, we need to focus on that. Um, Okay, but 10 to 15 minutes, not a lot of time. But if you shift it to much longer appointments, but fewer in a day, not
yeah,
only are you spending more time with the patient, but if we think about it from a GP perspective, a lot, a lot less burnout, a lot less risk of burnout. Because burnout is obviously a big problem
100%.
in the NHS generally. And I think GPs are obviously the forefront of the system. it could potentially be very, very beneficial for both parties.
Yes.
Um, so going back to this financial incentive issue, how exactly do we weed our way out of this?
Yeah.
How do we redesign the system? Are you involved with changing the way that incentives are structured?
Not directly, no. Indirectly, absolutely. This a lot of this is about you know, influencing policy, helping policymakers, NHS leaders think through what the different scenarios could be, and I've certainly had input into that. But ultimately, some of this is, demonstrated or proven in other parts of the world, and not wishing to get into the technicalities of this, but essentially what it requires is to have a upfront budget for the year for the individual. So it could be any, and I don't think the relevance of how much it is relevant at this point. It's more about the concept in that. So if, let's say, for Abigail, maybe not Abigail as a good example, but let's say you have Mrs. Jones, who's a 70-year-old lady who has one or two complex conditions that need ongoing management, but is living alone, has some frailty. If for individuals like that, we were given a pot of money at the start of the year, let's say at the start of the financial year, for the case of particularly this case, for argument's sake, we say £1,000. What that means is that when you get that initial upfront payment, then you can make various investments for Mrs. Jones throughout the year, which allow you to then think about the staffing, think about different touch points she needs, think about the different services she needs, which may include things like podiatry, hearing check, physio at home, mobility, strength, nutritionist. But again, it allows you to invest for her and her care with the view that you get that upfront, but then you get a bonus payment at the end for continuing to provide, you know, outcomes that have been determined from the onset, which may well be that, strengthening, better independence, better mobility, but also really good control of a complex clinical condition, which might well be blood pressure or diabetes, that you've met throughout the year. And you've got evidence of that because you've kept her blood pressure low 3 or 4 times a year. You've done the check and you've demonstrated that. You've kept her sugar levels low throughout the year because you focus on her nutrition, her lifestyle, but also inputted if she's on a medication. But my point being here, it's a very outcome-based healthcare type of view. It's also focused on, then, because it's population, population health budgets, then you can invest not only for the individual but for the population. But that is a very different way of thinking about things than it is to say I only get paid when someone joins my surgery, or then I get an uplift based on their risk and where I'm based. So that's what we mean by risk adjusted payments, outcome based payments, but also where we invest for the individual at the population level through a payment mechanism like that.
And where would you say that primary care is falling in the priority list for healthcare at the moment? Because I know that generally, obviously, the NHS is chronically underfunded.
Yeah.
Do you feel like primary care is getting the attention that it needs, or do you think that there still needs to be more attention paid to it, and other specialties are getting a bit more either funding or just more kind of technological information
Yeah.
innovation?
So look, the honest answer is that it's not about the speciality. It's more about the form of organizational structure. So what I mean by that is often it's primary care versus acute care versus mental health versus community care. So it's kind of how we organize care that gets attention rather than different specialities. Now, and this is often a well-cited fact that 90% on average, again guesstimation, 90% of interactions across the NHS happen in the primary care GP setting, whereas primary care GPs get 10% of the budget, vast majority of the budget going towards hospitals, which could be nearly up to 60 to 70%, mainly through things like staffing, hospital facilities, some of the capital expenditure, etc. So you can see there's a considerable amount of money that gets spent in the acute setting, but not necessarily where there is a lot of encounters or interactions. And so how we, again, shift that balance needs to be a key thing, which again often is talked about, but in reality quite hard to do and not very often done. And so the first protocol is how do we think about that? The second is that when we think about primary care, and I think this is a general problem because not many people understand general practice of primary care often at the policy and political level, because a lot of people who come through the ranks of NHS leadership come through the acute sector because they've managed large hospitals or they've managed large organizations that allow them to do that. But often, because they don't understand it, we get fixated with things like 8 a.m. appointments or how many GPs we have in a GP setting versus actually really understanding the crux of what primary care is, how we think about long-term condition management, how we think about the social side of primary care, how we think about elderly care, frailty, and then the list goes on, right? And now what we're seeing really is that we are seeing the blurring of boundaries between primary care, community care, mental health, and social care, because ultimately it's all coming together. So it's the acute sector and then everything else really, which is all coming together. And that's where we, and I say we, I would say the system, the NHS, the wider ecosystem hasn't quite grasped that as much as I would like or we would like to see. And I think that's work in progress, frankly. So, when we look at things like the NHS 10-year plan and we look at, good stuff that's coming out of Department of Health and so on and so forth, yes, it's important and there's a lot of good rhetoric around it, but in reality, things are very different because from a political standpoint, what do voters care about? They care about things like wait lists. They care about whether, again, Mrs. Jones has had her hip operation, whether, Mr. Patel has had his colonoscopy, those kind of things which are more diagnostic related, which are more treatment related, rather than worrying about how was my blood pressure managed, or did I get to see my health and well-being coach, or is my mental health better, right? The point is, those are the things that are, again, I believe, as equally important, if not more important, but that's not what wins elections. And I think that's where the political side of the NHS becomes important to understand. I think we're starting to see, again, a shift, and I think the biggest shift is coming because of the advancements we're seeing with technology and the role technology can play in a lot of this stuff, but also by understanding what's happening in different parts of the ecosystem. So again, we are across the country seeing lots of good examples of where this is happening and it's happening in a really good way, but that hasn't become mainstream yet.
Mm. That's really interesting because whenever you go online and if you try and find out what the issue is with primary care, if you try
Yeah.
and look for any reports, it's always quoting wait lists
Yes.
and patient demand, but it's almost like looking upstream of the river. It never goes to the actual cause, which is probably, like you say, it's systemic. It's the way the system is designed. Um, if let's think about GP shortages. Is this a big problem? Is it as big a problem as people make it out to be at the moment?
So again, it depends on what lens you're looking at and what what stakeholder you're kind of concerned about. Now, from a political and policy perspective, yes, it makes a lot of sense to shout from the rooftops to say we're short of GPs. But if we go back to what I was arguing earlier, which is that if we were really serious about developing a sustainable primary care model and we were thinking about other healthcare professionals first rather than doctors first, then the honest answer is no, we don't necessarily need more GPs. What we need is more health and wellbeing coaches. We need more nutritionists. We need more link workers. We need more physios, pharmacists, because of that multidisciplinary team nature of how we provide holistic preventative health versus episodic health versus I've got a sore throat or reactive health, which is where you may need more GPs. So again, it really depends on what the scope of the work is, what we want to focus on, and how we want to design the model and the operating model. So yes, if you're a policymaker, politician, you'll say we need more GPs, but in reality, if we were to design a prevention first holistic operating model, which is technology enabled, then we don't need more GPs, is my view.
Interesting. Let's think about so kind of along those lines. Are we seeing a recruitment crisis as well? Are junior doctors less inclined to join to train as general practitioners nowadays? Are we seeing more junior doctors leave the profession? Are we seeing more UK GPs leave the
Yeah.
profession? Do you know what's
No, I
going
think it's
on?
the other way around, actually. I think we're seeing record numbers going. I think GPs often tend to be the career of millennials and Gen Zs. Um, and the reason is because, as a generalist, it gives you the ability to have a portfolio, which I think a lot of millennials and Gen Zs like. They want to do different things rather than just stick with one thing. And it gives you the flexibility to pursue your interests in other activities, which is probably a good thing from the health and well-being of the individual, but it's probably not so good thing from a system perspective and NHS perspective, because if you can't get continuity with the same GP, or GPs are coming in and out, then you can see the frustration it plays in terms of planning as a manager, but also what it means for the patient. So look, then it means, how do you balance the weighing scales and how you think about it from different angles. But ultimately, we are seeing many more people pursuing a career in general practice as a GP physician versus going into other specialities. And it's also because it's a much shorter training pathway, which gives
Yeah.
more flexibility.
Okay. All right then. Maybe let's talk about tech as well, because this is
Yes,
something I think that you do some work
yes.
with and that you've spoken about. So, from my point of view, the biggest tech innovation that we've seen in primary care is probably ABTs, or sorry, ambient voice technology. Um,
Well, it
is
depends what you mean by
this?
biggest.
I guess. I guess the trendiest. I guess that's the
Trendiest,
word.
maybe
That's
one
the
of the most,
trendiest.
I would say one of the most game changing, absolutely.
Sure.
Yeah.
Okay.
In terms of biggest, I think bigger I would relate to, size of the prize versus, how much effort it takes to implement. But I think in terms of game changing over the last decade or two, I think absolutely ambient voice technology has been the game changing.
Awesome. But the thing is, you go to your GP, and you go through the general appointment, and you see that it takes about 5 years to load their computer because it's so slow.
Yeah.
Um, I had a diabetes appointment the other day, and the doctor was trying to book a phone call, and the system, it was just so utterly confusing. So I have no idea how you're doing this, and it took a long time to just book this simple phone call because it's very very clunky to use.
Yeah.
Um, so we've got ABT, but it seems like the whole IT system is lagging behind. Is that fair to say?
I think that's a fair comment. I think a lot of it comes down to the lack of investment we've had with things like, network systems, hardware, some of the software upgrades. I think cybersecurity has been a big problem in primary care setting because we've not invested as much, and we never thought GP surgeries could get attacked through cyber security issues. So, all of that plays out. Absolutely. I think some of the GPs probably are still working with Windows 10. They're still working off, old school, desktops. And the world's moved on considerably. Yeah, I would agree. But I think also the incentive for that often comes from general practices themselves rather than the system. The system does refresh now and then and gives a pot of money to GPs to invest in things like this. But I wouldn't say it's been hugely consistent. But putting hardware to the side, I think we're seeing a lot of advancements in software. You know, I'm a medical advisor to the Access Group, who I believe have a fantastic stack of technology tools that are being implemented across community and mental health, but also now across integrated care systems as a software thing. Combining things like ambient voice technologies into that, and trying to bring that glue together for multidisciplinary working and working across integrated care systems. And I think if we think about where primary care again is going into neighborhood health settings where you need to work with different organizations, and you need to coordinate the care, then I think it becomes a really important thing where more and more technology like this becomes important, and that's where I think has been a challenge in the past. But that's not all dependent on hardware. It's also dependent on having relevant, up to date, accurate software that can play a really important role. And that's what we're seeing slowly, but I wouldn't say it's mainstream yet.
How do we, because I've kind of heard different stories of why it is so hard to get new tech into the NHS. Some people talk about legacy systems, and old contracts kind of keeping trusts locked in
Hmm.
to using very old systems. Some people talk about just general funding. We just don't have the funding. But if it were a funding issue, then where do we get the funding from
Yeah.
to get more tech in? That's a big thing. Um, and some people, well, actually, I think those are mainly the two arguments that I hear. Um, so why do you think it is so difficult to implement
So,
new bits of tech?
sorry, I missed the first one. The second one you said was funding. What was the first one you said?
Legacy
Legacy. Yeah,
systems
sorry. Yeah.
and yeah, old contracts keeping trusts locked in.
Yeah, so from that perspective, hospitals I think are generally improving a lot on that. Yes, there's still a number of legacy systems, but quite a number of them now, I think nearly around 90 to 95%, if I'm not mistaken, are on an enterprise-wide electronic health record system, which I think is, a really big step forward. I think mental health is slowly behind. Community health is also coming down the track. Primary care has always, has been for the last 3 decades now, 100% enterprise-wide on electronic health record systems. So, but there are lots of other legacy systems that they use, but much smaller in scale from a practice by practice basis rather than from a hospital system. So yes, there is a lot of that, and I think the NHS probably spends about £500 million a year on legacy systems, which I think takes a bit of time to untangle, to decommission. But at the same time, yes, like you said, it's never really always been a priority either. It's one of those line items that we just continue with, which we could think about repurposing to some of the newer age stacks, technology stacks. Sorry, but I think that that's still work in progress. In terms of funding, yes, it's always been a challenge, but I think it's always been a challenge because we haven't been consistent with it. So what happens is that if you've not consistently have 1 to 2 or 2.5% a year of your balance sheet investing in technology, then after 10 years, you're going to have to put a significant amount of money in because you have to play catch up with all that time you haven't spent that money. So the challenge we've had is that technology has always been an add-on. It's always been seen as a nice to have rather than a must to have. But I think that mindset is now changing. It's changing considerably because we've seen advancements in that, but also with the advancements in artificial intelligence, what we're seeing with the likes of ChatGPT and others, the cost of actually procuring or implementing technology has come down considerably. And that's why now it's becoming a lot more about software than it is necessarily about large EHR deployments or implementations that we've seen in the past. So I'm hopeful for the future on how we can build on some of these legacy systems through fixes that we're seeing with the advancements in these tools. But that's still a space to be to work in. We haven't seen massive shifts yet, but that is only coming.
Interesting. Okay, so if you had to choose or predict what the next focus of tech in primary care is, if that makes sense, if you had to pick what our next either issue that we're tackling in terms of tech in primary care, or the next exciting development that we should be implementing, if you had to pick something
In primary care.
to focus on, yeah, what would you choose?
Yes, look, I'm super excited by again, this may not be an NHS focused thing, but I think globally, what we're seeing is that primary care is now becoming a core element of, sustainable health systems. But those parts of the world that may not have a, primary care infrastructure like the NHS has, are thinking about primary care in a very different way, which excites me because I think, if we were to create a primary care system today from a blank sheet of paper, we necessarily wouldn't design it like like the NHS primary care system is designed today, which what I mean by that, sorry, is you wouldn't design it around physical locations of 6,500 practices. You will most likely think about a digital first model. You'll think about a hub and spoke type of setting, but also you will think about it from a prevention first, healthcare coaching, healthcare nurses, health psychologists, health and wellbeing coach, all the things that we talked about first, rather than a doctor-centric model fixated around a particular practice with limited tech. So you would completely flip the model around, and you would restructure in a different way. And the stuff I'm doing out here in the UAE, but also other parts of the world, is exactly the type of excitement that's happening, right? And those parts of the world where technology is an important plays an important role because of access to mobile phones or cheap telecoms. Let's say Indonesia, Kenya, even India, actually, where we're seeing large populous nations, but they also do digital first, where they do in seconds payment to their market vendor to buy vegetables, or they can access whatever it might be online. Those parts of the world that are developing primary care are doing it a very different way. But I also think the definition of primary care is changing, right? You're seeing a divergence of primary care, which is more acute led, which might be things like sore throats, coughs, colds, urine infections, to on the other side, which is more continuity with long-term condition management. And I think that divergence means that the first part, you don't always need a general practitioner, but actually for the second part, which is on the long-term complex condition management, trust, relationship, ongoing continuity, prevention-led, prevention first, you're seeing more and more primary care veering towards that, versus more of the urgent care stuff that I talked about on the acute side. So again, all of that is changing, which is what's exciting me most. And I think, again, from a technology enablement perspective, I think we're going to see some really great innovation coming through the track, which is going to fundamentally change the scope of work, but also the outcomes for many patients around the world.
That's really cool. Conscious of the time, we'll
Yes.
wrap up soon. I think one last question is, so AI in a triage setting for primary care,
Yeah.
some people are very opposed to this, sorry.
Mhm.
Do they have a reason to be strongly opposed to the idea of AI triage systems?
Well, yes and no, right? I think if we're saying that it's now become mainstream, everyone has to use it, yes, of course, there'll be oppositions. If we do it in a safe, controlled way, and the regulators are more involved, to ensure its safety, but also its efficacy, then I think we'll probably see less resistance. I think inevitably more and more patients are using these tools. More and more people are using things like ChatGPT, Gemini, the list goes on in terms of diagnosing themselves, are coming with reams of paper on what could be wrong with them. So I think we need to approach this in a way that's, shared decision making with the patient, but also helping us to work with them rather than work against them. Because, frankly, when patients bring stuff like that to me, I learn a lot because often, the medical knowledge has advanced a lot. We practice what we've been trained on, but actually it's about the ongoing learning and the ongoing development. So I'm in all favor. Of course, there's going to be a number of individuals who are resistant to things like that. But, again, you take the bell curve of innovation, you're going to have your fast movers, then you'll have vast majority, then you have your laggards at the end. So why don't we focus on the fast movers and the vast majority? And I think we'll see a tipping point sooner or later. But
Okay,
safe, it has to be safe, quality assurance, regulated, high efficacy, because there are still a lot of challenges with a lot of these tools at the moment.
of course, yeah. Okay, so finally, you're going to be speaking at Rewired in
Yes.
hopefully not too long at all. Can you give us a little sneak peek? What are you going to be talking about at Rewired? What can we expect from there?
Yeah. No, so I'm excited. It's one of the flagship digital health technology conferences across healthcare in the UK. So great to be participating. A lot of my focus will be on neighborhood health and how we redesign neighborhood health, which is enabled through technology, and what the role of technology can play in this. So whether it's communication, whether it's note sharing, engaging with different teams, and doing team-based care. That's essentially what neighborhood health is about. So it's about how do we utilize technology in an effective way and design systems to enable to do that. So that's really what it's going to be like. So that's what it's going to be about. Sorry, as well as thinking about workforce from a different perspective.
Fantastic. Well, can't wait to see it.
No, I look
Thank
forward
you
to it.
so much.
Likewise, and look forward to
Yeah,
seeing you there in
no.
person.
Thank you so much for joining me today. It's exciting
Yes,
to watch the development of primary care and see how it's evolving and see how it's changing. So yeah, thank you so much for explaining this.
no
It's
worries.
been really